Sleep apnea and anesthesia. Obstructive sleep apnea is a descriptive term which includes a wide variety of conditions that eventually result in apnea during sleep. While the term obstructive sleep apnea syndrome is usually used in the presence of daytime sequelae. Apnea is defined as the cessation of airflow for more than 10 seconds, while hypopnea is the reduction of airflow for more than 10 seconds associated with the saturation of 3% or more and or EEG evidence of arousal. Apnea-hypopnea index is defined as the number of hypopneas and apneas per hour of sleep and is used to classify obstructive sleep apnea into mild, moderate, and severe. 5 to 15 is a mild case, 15 to 30 is a moderate case, while more than 30 is considered as a severe form of obstructive sleep apnea. There are two types of sleep apnea: obstructive and central, in which there is no respiratory effort and is the least common. Mixed type is present. The causes of obstructive sleep apnea are congenital or acquired. The common two causes: obesity and pharyngeal obstruction, tonsillar hypertrophy. Other causes of obstructive sleep apnea are nasal obstruction, craniofacial anomalies, laryngeal obstruction, neuromuscular disorders, connective tissue disorders as Marfan syndrome, storage diseases namely mucopolysaccharides, hypothyroidism, and chronic renal failure. The central sleep apnea is due to transient withdrawal or inhibition of central drive to the respiratory muscles. It may be idiopathic, it's called primary central alveolar hypoventilation. It may be related to disorders of ventilatory control following stroke or head injury, or disorder of neuromuscular function following poliomyelitis, dystrophy, and amyotrophic lateral sclerosis, and finally, due to excessive load on the respiratory muscles, obesity, airway disease, and kyphoscoliosis. The pathophysiological base for OSAS is a narrow, floppy upper airway, which is either congenital or acquired. This airway gets narrower and floppier during sleep, particularly during rapid eye movement sleep, stage of sleep during which muscle relaxation is profound. This has two consequences. Number one, as the turbulent airflow passes through the airways, the structure will vibrate, and this will produce snoring. The second, we get the Bernoulli effect, which will lead to collapse of the airway and produce obstruction. When this obstruction occurs, the patients become awake, and this will restore the muscle tone and breathing. And the cycle is repeated several times during the night, producing constant sleep disruption with subsequent daytime somnolence. Obesity causes OSAS for two reasons. Number one, the deposited fat tissue in the pharyngeal area will decrease its lumen and its patency and its redundancy, making it collapsible during sleep. Second, the deposited fat tissue in the neck externally will produce compression. It increases extraluminal pressure. So, the airway is compressed internally and externally, and the severity of obstructive sleep apnea is correlated with increased neck circumference rather than total body obesity. And a figure more than 42 centimeters neck circumference is considered as a risk of development of obstructive sleep apnea. There are four cardinal symptoms of sleep apnea. Number one is heavy snoring, and heavy is important. Number two, awakenings during the night with shockings. Third is witness apnea. And finally, daytime sleepiness as a sequence of repetitive awakening during the night. Other symptoms of sleep apnea exist, including headache, poor memory and concentration, repeated accidents, mood and personality changes, gastroesophageal reflux, nocturnal sweating, impotence, nocturia, and enuresis. In children, we have the following symptoms: snoring, restless sleep, somnolence, aggression and behavioral problems, hyperactivity, odd sleeping postures, frequent coughs and colds. In examining a patient with sleep apnea, you may notice the following: edematous lung, soft palate of the uvula, decreased oropharyngeal dimensions, nasal obstruction, maxillary hypoplasia, rectognathia, central obesity, increased neck circumference, consequences of cardiovascular consequences of SAS as hypertension and others, conditions or syndromes associated with sleep apnea. Investigations: full overnight polysomnography, videotape for body movements and transcutaneous carbon dioxide in certain occasions, nasopharyngoscopies, sleep endoscopy, upper airway imaging, and these will be of value in intratracheal intubation and airway manipulation. By polysomnography, we mean the electrographic monitoring of all physiological variables during sleep, and these include EEG, EMG for sleep staging, ECG, pulse oximetry, monitoring oronasal flow by pressure transducer or thermistors, monitoring respiratory effort by impedance or inductance tomographies, diaphragmatic EMG. There are several consequences of sleep apnea. First, neuropsychological, the form of reduced memory, cognition, headache, and anxiety and depression. On the cardiovascular system, we get hypertension, ischemic heart disease, heart failure, cerebrovascular accidents. On the pulmonary, we get pulmonary hypertension, hypoxemia, and hypercarbia, or type 2 respiratory failure. Due to effect of hypoxemia, we get polycythemia. On the endocrine system, there is decreased growth hormone and testosterone, along with diabetic instability. And finally, gastroesophageal reflux. Treatment: we have conservative methods in the form of reducing alcohol, sedatives, and so on. The use of appliances to manipulate the mandible may be of value in relieving obstruction. The classic of the ideal therapeutic measures here is nasal CPAP, which will relieve obstruction by splinting the upper airway. In severe cases, we may resort to post-pressure ventilation and the use of BiPAP. Some surgical operations are associated with OSAS, including tracheostomy and cricothyrotomy, which will be life-saving in the presence of severe hypoxemia. In general, prior to surgeries in these patients, a minimum period of 2 weeks would be extended to 1 month of nasal CPAP, which is great value in reducing the obstruction and the upper airway edema. Other surgical procedures are trimming of turbinates and dissection of septum, tonsillectomies and adenoidectomies, of course, uveopatopharyngoplasty, maxillofacial surgeries, surgery for obesity, and finally, hominium laser, which has the value of producing less edema. The effects of anesthesia and surgery on patients with OSAS. All stages of anesthesia and surgery are hazardous. Sedatives, analgesics, and anesthetics will precipitate OSAS by decreasing the pharyngeal tone, decreasing the ventilatory response to hypoxia and hypercapnia, and by inhibiting the arousal response to hypoxia and hypercapnia. Surgery of the thorax and the abdomen will impair ventilatory function, while those on the upper airway will produce post-operative swelling and obstruction. The use of nasal pack or nasopharyngeal or nasogastric tube will promote collapse by reducing the lumen of the upper airway, and they will interfere with the use of nasal CPAP. Finally, the supine position will precipitate upper airway obstruction. The pre-operative preparation include: look for associated medical diseases, assess the cardiorespiratory system by performing hematocrit, ECG, pulse oximetry. In the presence of severe hypoxemia or right ventricular dysfunction, more tests can be performed, include chest radiography for cardiac size and pulmonary edema, echocardiography to evaluate the ventricular function, cardiac catheter to diagnose pulmonary hypertension. Then pulmonary function tests can be performed, ABGs can be performed to assess, check hypoxemia and hypercapnia. Patients using nasal CPAP should bring their CPAP to be used post-operatively. The severity of OSAS should be assessed by looking for polysomnography, right ventricular failure. Upper airway evaluation is important. Look for obesity and its distribution. And of course, neck circumference more than 42 centimeters is a risk factor of obstructive sleep apnea. Premedication. Sedatives and opioids should be used very cautiously unless the patient is on nasal CPAP and he is well trained to use it. Appropriate oxygen monitoring. The insertion of IV cannula from the start to use an antagonist as required. Aspiration prophylaxis in the form of antacids is important. The use of anticellulogogues to reduce secretions because of the possibility of difficult intubation. Steroids may be needed to reduce edema. Induction of anesthesia. The application of local and regional techniques is the ideal for these patients. We can intubate the patient awake, and we may induce anesthesia as necessary. For awake intubation, it's usually easy due to reduced gag reflex in these patients. It can be performed with proper upper air anesthesia in the form of topical anesthesia and nerve blocks. And we can use fiber optic intubation, of course. General anesthesia is hazardous in this patient due to the following reasons. Number one, the possibility of difficult intubation. The induction of general anesthesia and the removal of muscle tone will precipitate OSAS. The loss of upper airway support will lead to obstruction and require difficult support will be difficult, particularly in obese patients. There may be rapid desaturation in this patient due to decreased functional residual capacity and because they have increased metabolic rate. Patients with pulmonary hypertension and right ventricular failure are intolerant to the hypoxia and vasoconstriction. The removal of hypoxic drive and the loss of upper airway tone. And finally, some patients have reported the development of pulmonary edema and heart failure with the induction of general anesthesia. The brief period of preoxygenation is wise because of the possibility of difficult intubation, though it has unpredictable effect on the respiratory drive. The advantage of inhalation induction versus intravenous induction is the reversibility, of course, and the decreased pulmonary artery pressure, but it has the advantage of myocardial depression. It's unpleasant, of course. However, sevoflurane is the best and is superior to halothane, which in turn superior to iso and influrane. Nitrous oxide is used cautiously for the possibility of development of pulmonary hypertension. The intravenous route has the advantage of no excitation, no vomiting, and laryngospasm. However, it may be associated with complete loss of upper way tone or upper way support airway, which is hazardous, and immediately you can go to jaw manipulation or insertion of airway, either oropharyngeal or nasopharyngeal airway, or even the application of CPAP. With induction anesthesia, the use of cuff intratracheal tube is the best method to secure the upper airway. Sometimes blind nasal intubation is resorted to. Of course, fiber optic intubation is an ideal method. The laryngeal mask airway may work very good in many cases, either following failed intubation or as an elective method from the start in some cases. The use of muscle relaxant should be one essential, and use the short-acting ones with the lowest effective dose, along with neuromuscular monitoring with peripheral nerve stimulator. The control method of mechanical ventilation is superior to spontaneous by reducing the inhalation agents, maintaining normal capilla. And it's been noted that matching the end-tidal CO2 and arterial and saturated pressure of oxygen to preoperative levels with adequate use of anesthesia will allow the avoidance of the use of muscle relaxants. Opioids should be used cautiously unless the patient needs CPAP. And finally, the extradural opioids are found to be safe. Extubation is done very cautiously because there is the risk of airway obstruction, which lead to death or lead to POP. In POP, there is despite the effort against an obstructive airway, which will produce a negative pressure in the interstitium with subsequent transudation into the alveoli. The choice between awake versus sleep extubation in upper utopharyngoplasty and nasal surgery depend on experience at the beginning of the operation and the condition of the patient, his cardiovascular system. Sometimes the choice between awake extubation versus leaving the tube for prolonged periods of mechanical ventilation, necessitating the transportation to the ICU. Anyhow, when extubation is planned, it should be in awake, fully reversed patients, tolerating sitting or lateral position. And removing the endotracheal tube is sometimes done over a caster for the necessity of re-extubation. And the nasal CPAP should be applied immediately after extubation. Monitoring is the standard method of monitoring in the form of ECG, blood pressure, pulse oximeter, and capnogram. The use of peripheral nerve stimulators is essential in the use of muscle relaxants. For severe cases of upper airway obstruction with right ventricular dysfunction, an arterial cannula should be inserted for direct arterial blood pressure monitoring and for monitoring ABGs. The use of a CVP or pulmonary artery pressure monitoring may be needed in some cases. In the recovery and post-operative periods, use the lateral position because the supine position induces obstruction. Oropharyngeal or nasopharyngeal airway may be required in some cases. The use of nasal CPAP for persistent obstruction for those previously trained on it. Oxygen can be added to the CPAP 2 to 4 liters per minute, and this will not affect the pressure of the CPAP. The problem of post-operative sedatives is circumvented by relying on the regional techniques, by the use of non-steroidal anti-inflammatory drugs, and of course by the use of CPAP. Post-operatively, the patient can be nursed with high dependency in certain conditions. Otherwise, there is no special nursing care is needed. Pulse oximeter monitoring for 5 days is required. In some cases, after relieving of upper airway obstruction, heart failure, pulmonary edema develops. It's been noted that the use of nasogastric tube may necessitate application of full mask rather than nasal CPAP. The removal of the valvular and lateral pharyngeal walls will prevent the effective use of nasal CPAP. Finally, 5 nights post-op are hazardous. And these are the indications of admission to the ICU or high dependency unit. Number 1, sedated or asleep are unable to apply their CPAP properly. Following upper airway surgery for the possibility of edema and obstruction. Those with complications, heart failure and pulmonary edema. Those who require prolonged intubation and mechanical ventilation. And finally, severe cases as those with right heart side failure or those with apnea-hypopnea index more than 30. And these are some questions, easy questions. Test yourself. Define apnea. Apnea is cessation of airflow for more than 10 seconds. Apnea-hypopnea index is the number of apnea-hypopnea per hour of sleep and is used to classify or assess the severity of obsess. As we said before, more than 30 is severe, 15 to 30 is moderate, less than 15 or 5 to 15 is mild. The two common causes of obsess are obesity and pharyngeal obstruction. The principal pathophysiological basis for obsess is narrow floppy airway, which gets narrow and floppier during sleep due to profound muscle relaxation. We have two consequences: snoring due to vibration of the structure and obstruction by Bernoulli effect. The patient becomes awake and he restores muscle tone, and the procedure is repetitive during the night, producing sleep disruption and daytime sequelae and daytime sleepiness. Apnea occurs during sleep during muscle relaxation. The 4 cardinal symptoms of obsess are heavy snoring, awakenings with choking, witness apnea, daytime sleepiness. Polysomnography is the monitoring, electrographic monitoring of all physiological variables during sleep, including the EEG and MEG for staging of sleep, the ECG, the pulse oximetry, measuring of all nasal flow, and measuring of respiratory efforts. And CT and cerebral state apnea. All sedative and hypnotics reduce the pharyngeal tone and state apnea. They inhibit the response to hypoxia and hypercapnia. They inhibit the arousal response to hypoxia and hypercapnia. Surgery on the upper abdomen and thorax impaired ventilation, or those on the upper airway produce edema. Supine position instead of obstruction. The application of nasal pack or gastric tube will reduce the lumen and promote collapse, and they will interfere with the application of CPAP. Monitoring the standard pulse oximeter and the arterial cannula or CVP, as I said before. The consequences of upper airway obstruction are either death or POP. And finally, the indications of admission to the ICU are those using sedatives, opioids in large doses, and they are not trained in the use of CPAP. Severe cases of obsess, patient with upper airway, of complications develop intraoperative in the form of heart failure, pulmonary edema, and so on. Thank you.